They've been down here for a while.
Was he here?
Put you and Bob Woolman together. Either important or in trouble.
I'm going to start right away as we get seated so that we can proceed, since the votes delayed us a bit, but not dampened our enthusiasm to hear what our witnesses have come to say. So I will try to follow my own advice as I say to my colleagues, the sooner we finish speaking, the sooner we can hear from our witnesses. I thank Congresswoman DeLauro and Congresswoman Donna Edwards, the co-chair of the Steering and Policy Committee, for convening this meeting today. I salute Ranking Member Elijah Key, Ranking Member Frank Pallone of Energy and Commerce for their leadership on this subject, as well as Congressman Lloyd Doggett, who has been a champion working on all of this. And we've also been joined by Congressman Jim McDermott, who is the ranking member on the Health Subcommittee on the Ways and Means Committee. Additionally, we have Congresswoman Jan Schakowsky of the Energy and Commerce Committee, and Congresswoman Terry Sewell of Financial Services. And Debbie Dingell. Oh, they're all coming in. So Congresswoman Debbie Dingell of Michigan, a leader on this issue. Today, soaring prescription drug prices represent the fastest growing sector of healthcare cost in our country, a surging burden on our budget and on the pocketbooks of millions of seniors and families across America. When we passed, I'll be just very brief, when we passed the Affordable Care Act, the idea was that we would have access, affordability, and improved quality of care for as many Americans as possible. The idea was that with our research that we invested in Rosa's committee on supporting the NIH, the investments there for research and innovation that helped in a public-private way to create new drugs, those drugs would be available, accessible, affordable to the people who had access to the Affordable Care Act and beyond. That doesn't seem to be the case. These high drug costs have perversely incentivized less effective and often more ultimately expensive courses of treatment. And again, I'm going to submit my statement for the record so that we can shortly hear and be deeply grateful to our witnesses, Lynn Quincy, Dr. Jeremy Greene, Brian Lehman, and Andrea Maresca. We look forward to hearing your stories and your solutions so we can confront these challenges. Thank you to all of the advocacy organizations involved in this shared fight. Thank you all for joining us to improve the health, economic security, and peace and well-being of America's families. And with that, I'm pleased to yield to our co-chairs of Steering and Policy Committee. Thank you.
Thank you very much, and good afternoon to all, and a welcome to our distinguished panel today. And a big thank you to Leader Pelosi for calling this important hearing on the rising prescription drug costs. I'm pleased to join my co-chair of the Steering and Policy, Donna Edwards, my other colleagues, and our distinguished panel. We know all too well how grave the challenge is of the skyrocketing cost of prescription drugs. According to a recent Kaiser poll, 77% of Americans see this issue as a top priority for Congress. And with the overnight increases on vital medications, it is no surprise Americans feel this way. Examples: Turning raised the price of Daraprim used to treat conditions associated with HIV by over 5,000%, from $1,350 to $750 per pill. Valiant raised the price of Nitropress used to treat congestive heart failure by 212%, from $258 to $806. Valiant also raised the price of Targradin gel used to treat skin cancer by over 1,600%, from $1,600 $1,687 to $30,320. Just this week, the Senate Finance Committee reported that Gilead, the maker of Sovaldi, the breakthrough hepatitis C drug, focused on maximizing profits instead of treating the greatest number of patients when determining how to price their drug. The $84,000 price tag significantly affects patient access. As a result, some Medicaid programs restricted access to only the sickest patients. And meanwhile, Medicare Part D spent more on these drugs in the first 6 months of this year than it did in all of 2014. Every day, we all see the threat that spiraling drug costs pose to Medicare, Medicaid, and the AIDS Drug Assistance Program. Through my opportunity as a senior Democrat on the Labor, Health, and Education Appropriations Subcommittee, we witness this all of the time. People all over this country are suffering, especially seniors and those with serious conditions. Now is the time for the Congress to take action, which is why several of my colleagues have formed the Affordable Drug Pricing Task Force. And last month, we were joined by senior Democrats in calling for Congress to investigate rising drug costs. This hearing is just the beginning of our fight to rein in the high drug prices and put people ahead of profits. I thank the leader. Congresswoman Donna Edwards.
Thank you very much. I thank the leader and my co-chair, Rosa DeLauro, and all the members who've joined us. Want to take a moment to acknowledge we've been joined since by Representative Gwen Moore from Wisconsin, Representative Susan Davis from California, our caucus chairman, Representative Javier Becerra from California, and Congresswoman Yvette Clarke from New York, and we thank you. As our colleagues have said, over the last several months, we've seen one article after the next from national newspapers, from the New York Times, Washington Post, Wall Street Journal, and on about pharmaceutical companies buying up rights of older existing drugs where all the costs for research have already been recouped, and then they still raise prices, and sometimes even overnight. In response, insurance companies are cutting benefits, increasing costs to consumers who've worked hard all their lives and earned their health care benefits. Many of our constituents simply cannot continue to afford to pay these out-of-pocket expenses on a fixed income. So what happens? Well, in some cases, Medicaid won't pay. In other places, private insurance won't pay. In other cases, people simply won't take the medicine anymore, and they go without. Many of us have called on colleagues on authorizing committees in both House and Senate to hold hearings on the price gouging. And since they haven't, we are here today. The purpose of life-saving drugs is just that. It's to save lives, not to line the pockets of the big pharmaceutical executives and investors. We owe it to the people we serve, the people who elect us, to put a stop to the price gouging that's bankrupting patients and overcharging Medicare, straining hospitals, and fleecing taxpayers. Maybe by outing each and every one of these drug companies and putting pressure on them, even shaming them, they might change their tactics. And with that, I would yield to Congressman Levin, who is not here.
Okay.
We'll yield to Mr. Pallone.
Thank you, Congresswoman. I want to thank Leader Pelosi and you, Congresswoman Donna Edwards and Rosa DeLauro, as co-chairs for having this important hearing. And I know that we have this task force with Lloyd Doggett and Jan and others here today who are really taking the lead on this. I think we could all agree that drugs save lives. In some cases, they can even cure disease. But the truth is the high cost of prescription drugs has become an all too common headline across the country, and with it has come increasing concern from patients. More than 70% of the American public think that the cost of prescription drugs is unreasonable, with 3/4 believing the high cost is due to pharmaceutical companies setting the prices too high. And high-cost new cures like Sovaldi, I think Congressman DeLauro already mentioned it, are not only impacting the pocketbooks of American families and seniors, they're also impacting federal health care programs. Medicare spent $4.5 billion on drugs to cure hepatitis C in 2014, which is more than 15 times what the program spent in 2013. And earlier this year, the VA had to stop treating veterans with hepatitis C for a time because it exceeded the $700 million budgeted for the drug. This in spite of the negotiating a 40% discount. So the VA, unlike Medicare, can actually negotiate. And they negotiated a 40% discount, but even with that, they ran out of money. Meanwhile, we're also seeing egregious behavior by certain drug companies like Turing, which I think Rosa also mentioned, who buy the rights to old neglected drugs and immediately spike the prices overnight, in some cases by 5,000%. So as the cost of certain prescription drugs continue to rise, and with the impact to our federal programs, we have an obligation to examine how these drugs are priced and paid for by the federal government. I would, however, urge that as we examine policy solutions, that we work together to find solutions that will strike a balance between preserving patient access while also continuing to encourage innovation and discovery of new, more effective treatments for the chronic illnesses that so many people are suffering from. And again, I look forward to continuing this conversation. I know this is the beginning of our process here with the task force, but this is a very important day, and this hearing is the beginning of our digging into this issue. Thank you again. I don't know who I yield to next. Congressman Cummings.
Thank you, Leader Pelosi, Congresswoman DeLauro, and Congresswoman Edwards for bringing us together for this very critical hearing. We're here because hardworking Americans are sick and tired of facing sticker shock every time they go to the drugstore. By now, we have all heard from how a former hedge fund manager, Martin Shkreli, the CEO of Turing Pharmaceuticals, jacked up the price of Daraprim, a drug used by cancer and AIDS patients, by 5,000%. He did this overnight, the same day he acquired the drug in August. Then, just last week, his company issued a press release bragging that he was lowering the price of this drug for hospitals by 50%. With all due respect, how dumb does he think the American people are? Our constituents just celebrated Thanksgiving, and many of them started their holiday shopping last weekend. Can you imagine going to the store on Black Friday for a 50% off sale and then finding out that the store jacked up its prices by 5,000% the night before? It's ridiculous. Even with the price cut, hospitals will now be paying about $375 for just one tablet of Daraprim, when less than 6 months ago, the same hospitals paid only $13.50 per tablet. Madam Chair, I wrote to Shkreli just this morning asking that he stop obstructing congressional oversight and finally produce the documents I've been requesting literally for months. I asked that my letter be made a part of the record. And let me close by thanking you again for holding this hearing. Democrats are ready to take action to address this crisis, but the House Republicans continue to pretend like it simply does not exist. They promise to look into it, but they kick the can down the road while Americans get sicker and while Americans die. To date, they have refused to sign even one letter to one drug company requesting information about the skyrocketing price of even one prescription drug. So I'm pleased that we're here today, and this is the beginning of a fight that we have no choice but to fight. And I yield now to Mr. McDermott.
Thank you. Thank you to the committee for talking about this issue today. One of the issues that we face, I'm here, I got 1 minute, so I got two questions I want to get to the panel. The first thing is that the pharmaceutical industry says that they have to make all this money because it costs so much to produce drugs, and they have to spend so much on research and development, and they just can't get away without, but their profits, they're the best stock to buy on the market. And half of the research was done under federal money from the National Institutes of Health and other programs that have operated. And I would like to hear from the panel how we should make a judgment about what real R&D goes in and what is it for overhead and marketing. The second thing, I'm a sports fan, and I hate to watch a Seahawks game and watch one advertisement after another for Ambien and Cialis and all the other drugs that are advertised through direct advertising. Dr. Greene specifically, I'd like to hear what you think the impact of the direct advertising is on the cost and the use of medications in the society. Thank you.
Thank you very much, Congressman McDermott, and we will get to the questions in a bit. Thank you so much. Congressman Lloyd Doggett of Texas.
Thank you, Leader Pelosi and colleagues. This really is a matter of life or death for too many Americans, and for healthcare providers and those who are paying for healthcare, it's make or break. For too many people, a diagnosis of cancer or other serious disease is also a prognosis for bankruptcy. Exorbitant drug prices are not just about one company or one outlier. They're not just about generics or about brand names. They're not about one manufacturer. They're about a pervasive systemic problem that is a pocketbook issue for American families, especially for seniors on a fixed income, even for those who have an insurance policy. In one recent survey by 700 pharmacists, virtually every respondent indicated there had been a large upswing in the acquisition cost, even of generic drugs, over the past 6 months. And this claim of innovation versus accessibility is really a false choice. U.S. consumers for the top 20 selling medicines are on average 3 times higher than in Britain. Take Nexium, for example. Here, $215 versus $42 in England, versus 23 other hearing rooms. If you go down this row, Mr. Cummings for over a year has tried to get hearings on this. Mr. McDermott has called for hearings in our Health Subcommittee. Ms. DeLauro has called for hearings in the Appropriations Committee. In the Commerce Committee, Ms. Schakowsky and Mr. Welsh have been unable to get hearings on their bills. We want this to be a bipartisan issue. Republicans are affected by this also, but their representatives here in Congress have yet to join with us in a true bipartisan effort to find the legislation, and it's not just one bill, to address this. Finally, we need to be asking the administration, as we have been in so many areas, to use its full executive power to do what it can within existing laws, whether it's the FDA, the NIH, the CMS, or any other part of the alphabet soup. We need to use every part of the federal government we can to address this crisis. I thank you.
Thank you very much, Congressman Doggett. Before we begin the introduction of our witnesses, let me tell you that we have been joined by Congressman Tim Ryan of Ohio, Congresswoman Diana DeGette of Colorado, and Congressman Peter Welsh of Vermont. Did we miss anyone? Everybody else? Okay. Then let us proceed. Again, we want to thank our panel. I want to start by introducing our witness, an experienced consumer advocate and an innovator, and that's Lynn Quincy. Lynn has a long history of working on a range of health policy issues. She's focused primarily on the areas of consumer protection, strategies that provide better value for our healthcare dollar, and health insurance reform at the federal and state levels. She is an innovator, as I've said, because she recently launched the Healthcare Value Hub, serves as its director under Consumers Union. It is a new center that monitors, synthesizes, translates, disseminates evidence about interventions to improve value in our healthcare system. Their mission is to support and connect consumer advocates across the U.S. to help them advocate for change. Her work with Value Hub demonstrates the need for reliable information when it comes to comparing treatments in pricing and effectiveness. She researched and analyzed more efficient solutions to our healthcare system in the past, and she has a lot of experience in creating effective solutions to our healthcare problems. She will share with us how the recent spike in drug prices is limiting consumer access to life-saving drugs and thereby affecting overall health outcomes in our country. She is going to also offer us some recommendations for combating the rising drug prices. We thank you, Lynn, for being here and for sharing your insights with us. We look forward to your testimony.
Okay. Are you introducing everyone, or should I begin?
No, you go forward.
Okay, thank you. I was given a slightly shorter time frame, so if I don't, I look forward to your questions if I don't address everything. So anyway, good afternoon, Leader Pelosi, Congresswoman DeLauro, Congresswoman Edwards, and members of the steering committee. I'm delighted to be here on behalf of Consumers Union, which is the policy and advocacy arm of Consumer Reports. We're talking about a very important issue, drug pricing and how it affects consumers. I know you're not strangers to Consumer Reports, but just as a reminder, we are an expert, independent, nonprofit, mission-driven organization. We've been around since 1936, working for fair, just, and safe marketplace for all consumers. As has already been mentioned, Americans benefit from an abundance of drugs that cure diseases, alleviate symptoms, and prolong life, and that's the good news. Unfortunately, high and rising drug prices are a grave concern for consumers around the country. Our own nationally representative survey found that over 30% of people who regularly take a medication have experienced an unexpected spike in their drug costs in the last 12 months. And these spikes can range from a few dollars to over $100 per prescription. And they're really hurting, as you can imagine. Just today, or it might have been yesterday, we took off embargo an article that will appear in next month's magazine about the variation in drug pricing around the country. There's a lot of stories about how it's affecting consumers in there, and I'll reference just one of those stories. Denise N., age 49, from Lincoln, Nebraska. Anyway, in July, she went to pick up her medication, and she found the price had nearly doubled. And we'll be talking about the reasons for these spikes, but in her case, it was due to a shortage on the market. Many of the stories you hear and that are getting front page in the newspapers have to do with extremely high-priced drugs. But one of our messages is we want to remind you that consumers are being challenged to afford everyday drugs. There are, just as an example, 29 million Americans have diabetes. Many of them will have to take diabetes medicine for the rest of their lives. That's 10 times the number with hepatitis C. Insulin, invented in 1921, is still not off patent. In 2014, for the fourth year in a row, spending on diabetes drugs was higher on a per-member basis than for any other class of traditional drug. So our problems are widespread. They're not isolated with some of these to just these extreme examples, but thank God they've focused the spotlight on the problem. When people can't afford their medications, they frequently cut corners in ways that can be harmful to their health. They may not fill a prescription, they may arbitrarily cut their dose or otherwise not take the medicine as prescribed. And as you can imagine, it's very well documented this leads to poorer health outcomes and higher healthcare costs down the road. So if we're going to address the problem, we have to be familiar with the reasons for these high and rising drug costs. One of the things that will be reported is consumers' own share of the costs. They are reporting higher shares because maybe their drug has been placed in the highest cost-sharing tier in the drug formulary. And that highest cost-sharing tier is extremely expensive. It's typically coinsurance, so maybe you're paying a 50% coinsurance for a drug that costs $2,000. Other things that they're experiencing are that the formulary may drop their medication mid-year, and then they face a price spike because they've got to replace it with something else or keep taking it even though it's off formulary. So just their cost share is one source of consumer story that we hear. But it's very important, and I know the members of the steering committee know this, that we also examine the total price of the drug and what's driving those costs. And there's myriad reasons, as has already been mentioned, things like high research costs, long periods of market exclusivity, insufficient competition, and drug material shortages. So there's a lot for this task force to examine. It seems clear that many manufacturers are charging more than they need to recoup the costs of R&D. To introduce another example, in his seminal article for Time magazine, Stephen Brill found that the cancer drug Rituxan cost just $300 to manufacture and ship. The manufacturer then turned around and charged $3,500 to the hospital. The hospital, in turn, charged the patient $13,000 for that drug. The markups are unbelievable. I'll conclude by reminding you that survey data shows Americans on both sides of the political aisle believe that only the government can step in and address these problems. The market is not going to solve these problems. I thank you for your attention. I look forward to your questions, and I congratulate you on the formulation of the task force.
Thank you very, very much, and thanks for your being so focused and observant of what's happening. I'd now like to introduce Andrea Maresca, the Director of Federal Policy and Strategy to the National Association of Medicaid Directors. Andrea is very familiar with the problems of high prescription drug prices. She has seen firsthand the impact to Medicaid budgets. My history with Andrea goes back before her advocating for state Medicaid directors. In early 2000, Andrea was a legislative assistant handling health policy. Prior to joining the Medicaid directors, she managed health policy for the National Governors Association. Today, she is going to share the challenges that the Medicaid agencies face when confronted with rising and high prescription drug prices. Specifically, she will discuss how Medicaid directors are being forced to make difficult coverage decisions for Sovaldi, the breakthrough hepatitis C drug. And we're delighted that you're here, and it's great to see you again, and look forward to your testimony.
Thank you. Thank you, Leader Pelosi, Congresswoman DeLauro, and Congresswoman Edwards, and all members present today. I appreciate the opportunity to speak with you about an issue that is of utmost importance to the National Association of Medicaid Directors and the state Medicaid agencies that we represent. NAMD is a nonprofit bipartisan organization that represents the 50 state Medicaid directors, the director in the District of Columbia, and the territories. We work in a bidirectional way to translate the experiences and the needs of state Medicaid directors to policymakers at the federal level, and we also work to communicate with our members about the top priority issues and initiatives that members of Congress are engaged in, as well as the administration and all the stakeholders that interact with the Medicaid program. We have appreciated the opportunity to work in a bipartisan fashion with many of you and with the rest of the members of Congress on key issues such as the Part B premium increase, which was scheduled to take effect, and the mitigation in the policy that was eventually enacted, which would have otherwise had a significant policy and financial impact on state Medicaid programs. Similarly, this issue of pharmaceutical pricing and coverage is one that is top of mind for our members. Pharmaceutical pricing and coverage issues have long been an issue for Medicaid, which has statutory and regulatory obligations like no other program in the country. While state programs are guaranteed a certain level of rebates, Medicaid is constrained by its requirement to cover all drugs approved by the Food and Drug Administration. Unlike any other payer or program, Medicaid cannot assess certain pharmaceuticals to be low enough value to refrain from covering. Medicaid's inability to operate a closed formulary places states at a distinct advantage in trying to maximize the value of the taxpayer dollars invested in the program. While Medicaid has struggled to balance cost and access in the pharmaceutical space for years, the introduction of Sovaldi represented what many have called a breach of the social contract, wherein the manufacturer established orphan drug pricing for a very mainstream drug. Medicaid covers approximately 1 million of the estimated 3 million Americans currently infected with hepatitis C, a figure that does not include incarcerated or other justice-impacted populations, which may likely find themselves on Medicaid in the future. Other pharmaceutical issues are facing state Medicaid programs, including the rapid rise in the cost of certain generics, as well as products that can be described as branded generics, and the extremely high price tag of recent and future developments in specialized medicine. We were fortunate to have the opportunity to provide early information that helped demonstrate the need for the robust bipartisan investigation that led to the report issued out of the Senate yesterday. Today, I will share with you data based on an analysis that we helped inform in which 34 states responded. This represents approximately 73% of Sovaldi, otherwise known as Sovaldi. The most common criteria were documented liver fibrosis and sobriety requirements. 85% of the responding states required documented liver fibrosis for Sovaldi. 82% of respondents required some level of sobriety, though the number of months required varied from none to 12 months. Emerging research is showing the implications of ongoing addiction when treatment is started for individuals who are still dealing with addiction conditions. Most states require Sovaldi to be prescribed by or in consultation with certain specialist providers. And it's important to understand that states have been engaging in an evaluation of their policies and continue to work with their pharmaceutical and therapeutics committees or other advisory bodies to evaluate the appropriateness of the criteria, as well as working with their managed care programs and plans to ensure that policies are as aligned and appropriate as possible given the information that is available to them. Pre-rebate Medicaid spending on hepatitis C drugs increased from approximately $169 million in 2013 to over $1 billion in 2014, a nearly six-fold increase. Excuse me. Let me be clear that we are not undermining or in any way being critical of the value of Sovaldi or any particular product. We are simply saying that we need more and a more robust conversation around balancing access, innovation, and the cost to Medicaid, to consumers, and to taxpayers as a whole. We believe the experience with Sovaldi is a cautionary tale of what is to come with other truly important pharmaceutical products and demonstrates the need to have such a robust conversation. We look forward to working with Congress on policies that begin to tackle these difficult issues and strike a better balance. Thank you.
Thank you. At this time, I'd like to recognize Dr. Jeremy Greene, who's an associate professor of medicine and history of medicine at the Johns Hopkins University School of Medicine in Maryland. He serves as the Elizabeth Trady and A. McGehee Harvey Chair in the History of Medicine. Dr. Greene received his MD and PhD from Harvard in 2005 and completed a residency in internal medicine at the Brigham and Women's Hospital in 2008. He also continues to practice as a general internist in a busy community health center in East Baltimore. Dr. Greene's broader research interests focus on the history of disease, the history of global health, the relationship between medicine and the marketplace, and the history of therapeutics, especially pharmaceuticals. And he has written and published in a number of areas related to generic drugs and to the industry. Thank you, Dr. Greene, and welcome.
Thank you. Leader Pelosi, Representative Edwards, and Representative DeLauro, and all members of Congress here today, thank you for the opportunity to speak before you today. The increasing cost of older drugs is a problem that concerns me both as a physician and a historian of medicine at Johns Hopkins. And a few months ago, I treated a patient with...
Dr. Greene, is your microphone?
Oh, my goodness. I see a green light.
Move it closer to your mouth.
It's supposed to be right against my mouth.
I think it's supposed to be red. No.
Now there's no light at all.
Push it again.
All right. Sorry to violate procedure. I'll begin again. Leader Pelosi, Representative Edwards, and Representative DeLauro, and all members of Congress here today, thank you for the opportunity to speak before you today. The increasing cost of older drugs is a problem that concerns me both as a physician and a historian of medicine at Johns Hopkins. A few months ago, I treated a patient with pinworm, a parasite that affects roughly 40 million people in North America. And though she had no insurance, I sent her to the pharmacy convinced that the right drug would cost a few dollars at most. This drug, albendazole, was introduced in 1971. By the 1980s, its efficacy was so clear and its cost so low, just pennies a pill, that it was added to the essential drugs list of the World Health Organization. I was not prepared to see her return to my office an hour later with news that the drug now cost more than $150 per pill. I learned that in 2010, the U.S. market for the drug had been cornered by a small company called Amedra, which raised its prices. Medicaid spending on this one drug jumped from a mere $100,000 in 2008 to more than $7.5 million in 2013. For people without insurance, like my patient, the drug became basically inaccessible. This committee has already discussed the price hike and closed distribution of pyrimethamine, or Daraprim, another old drug bought by the same company, Amedra, and sold to Turing earlier this year. Turing's CEO claims that the higher price of the drug could easily be absorbed, if not by patients, by the healthcare system. Yet there have been real consequences for real people who need it. Recently, a team of my colleagues at Johns Hopkins admitted a patient who was stable for years on this drug before the dormant parasite in her brain reawoke once Turing raised prices and eliminated the distribution of the drug to most outpatient pharmacies. As an inpatient, she suffered a further downturn in her clinical status when Turing took 4.5 days to respond to urgent requests to resupply the drug. This problem is not limited to a handful of bad apples like Amedra or Turing. I have seen patients on the verge of hospitalization for asthma because they can't afford their albuterol. This is a drug first marketed in 1968. In recent years, old treatments for diabetes, gout, heart disease, and even the humble bag of IV saline have become newly expensive. These commodities represent a vital infrastructure of our healthcare system, now eroding through shortage after shortage and price hike after price hike, as new monopolies limit access to old medical interventions. I'd like to pause here and just point out that this is not a Democratic or a Republican issue. This is an issue that affects Americans. Solutions to this problem have been proposed from both sides of the aisle, but these answers are all premature if we do not understand how drug prices are actually determined. What we imagine as a free market for generic competition once drugs go off patent turns out to be a space crowded with intermediaries whose impact on supply and demand are poorly understood at best. My colleagues in the field of pharmacoeconomics have to work with fictitious concepts like the average wholesale price of drugs, which does not really have a bearing on what the actual drug prices are that are paid. Congress alone, I would suggest, Congress alone holds the power to illuminate how the hidden pieces in the puzzle of drug pricing actually fit together. As a historian, I reflect back here today, being on Capitol Hill, and thinking how Senator Estes Kefauver's subcommittee on antitrust and monopoly 50 years ago faced a similar set of problems and was able to respond with the power of the subpoena. And I urge you to use the power of subpoena to requisition documents and testimony from all players in these new markets for old drugs, to follow the molecule from production to consumption and understand where and how prices are being distorted so that we can maintain access to essential drugs for years to come. Thank you very much.
Thank you very much. And at this time, I'd like to recognize Brian Lehman, who's the Manager of Pharmacy Benefits and Policy at the Ohio Public Employees Retirement System, OPERS. It's the 11th largest public retirement system in the United States. Mr. Lehman focuses on managing program services and plan design aspects of the retiree prescription drug program, and also focuses on influencing pharmacy policy and regulations impacting the retiree prescription drug program. He's been involved with legislative and regulatory efforts to improve patient access to affordable medications such as generics and biosimilars. And Mr. Lehman has been engaged in writing comment letters to the U.S. Food and Drug Administration and the U.S. Department of Health and Human Services, as well as partnering with vendors, trade groups, and coalitions. And today we welcome him for his testimony.
Thank you. Thank you, Leader Pelosi, Chairwoman Rosa DeLauro, Donna Edwards, and members of the Steering and Policy Committee for this opportunity to talk. My name is Brian Lehman. Again, I'm the Manager of Pharmacy and Benefits and Policy at OPERS. And OPERS manages $12 billion for 1 million future and current retirees. We provide comprehensive medical prescription drug coverage for 227,000 non-Medicare and Medicare healthcare program participants. Today, I'm pleased not only to represent OPERS, but also as a member of the Public Sector Healthcare Roundtable. The public sector had healthcare coverage on behalf of millions of active and retired public employees and their families. Public sector entities from the Roundtable are supportive of Secretary Burwell's efforts to balance pharmaceutical innovation with affordability, while having the patient at the center of care delivery. We support policies designed to remove barriers to the development of innovative medicines that improve patient outcomes. But we as healthcare purchasers and our healthcare plan participants are challenged with the affordability of drugs, specifically specialty and biologic drugs. Specialty drugs are used in the treatment of conditions such as cancer, autoimmune diseases, and rare diseases. They're structurally complex. They often require special handling or delivery mechanisms such as infusion or injection, and are typically priced much higher than traditional drugs. Biologic drugs are a subset of specialty drugs that are complex molecules derived from living or biological sources. Historically, the national health expenditures average annual growth of prescription drug spend per capita was 7.2% in the 1970s, 11.7% in the 80s, 10.5% in the 90s, and then in early 2000, the average annual growth rate peaked, then declined over the years to 1.9% or lower in 2010 through 2013. But in 2014, U.S. spending on medicines increased 13% to $374 billion. This was the largest percentage increase since 2001, according to IMS Health. For 16 public sector entities, including CalPERS, Employees Retirement System of Texas, State of Florida, and OPERS, with 4.3 million lives, the expenditures on all drugs increased 10.6% to $6 billion in 2014. Especially biologic drug expenditures grew 23.7% to $1.6 billion. Especially biologic drugs only accounted for 2% of total prescription drug claims, but accounted for an astounding 26.7% of total drug expenditures. Over the next 5 years, specialty biologic drugs will continue to drive drug spending growth. For public sector entities who provide healthcare coverage, specialty drugs will account for 50% of overall drug spend by 2020. And OPER specifically, it will occur by 2019. Simply put, these increases for specialty biologic drugs are unsustainable for healthcare purchasers like OPERS or CalPERS, but more importantly for our participants and the millions of Americans who rely on these drugs. Drugs like Sovaldi that provide a cure for hepatitis C are too costly at $84,000 for a course of treatment for Americans to purchase. For these drugs to fulfill the promise of improving patient outcomes, they need to be priced to ensure affordability and access. Especially biologic drugs are driving overall spending due to new drug treatments, higher list price, and price increases. The pipeline is robust with 225 new products by 2020. Manufacturers are developing products that can command high prices, such as breakthrough therapies, as well as orphan drugs that have an average cost of $137,782,000 per patient per year. Especially biologic drug prices, excluding discounts and rebates, are continuing to grow dramatically. Drug spending increases are driven by high and growing drug prices will continue to affect healthcare purchasers and participants. Higher prescription drug spending will be passed along to individuals in form of increased healthcare premiums as well as increased out-of-pocket costs through prescription drug deductibles, coinsurance payments, and out-of-pocket maximums. More importantly, an increasing number of individuals may be unable to afford the prescription drugs that they need to stay healthy, leading to poor health outcomes and higher overall healthcare costs. A public sector roundtable specialty drug survey found that public sector entities have three major future concerns: the increased financial hardship on members due to higher cost sharing, the uncertainty of their organization's ability to continue to provide a high-quality health plan, and medical complications due to decreased medication adherence. In conclusion, we ask for your support on biosimilars and interchangeable biosimilar marketplace that will provide needed savings for healthcare purchasers and patients, changing how we pay for drugs to pay for value through value-based purchasing outcomes, based purchasing, as well as comparative effectiveness, and protecting our ability to utilize plan design and utilization management tools to manage our healthcare coverage. We are pleased to work with you and other stakeholders to advance these ideas. I appreciate the opportunity to testify today and would be happy to answer any questions you may have.
If she's prepared, we're ready to like to acknowledge Jan Schakowsky from Illinois.
Thank you so much. This is an issue that I've been working on for a very long time, and in the Energy and Commerce Committee, along with my colleague, Peter Welch. And I wanted to just run by you some solutions, but first just say, new data tells us that about 1 in 4 Americans don't fill a prescription because of the cost, 25%. 18% skip doses, 17% take expired medication, 15% cut pills in half. So first let me just ask you, anyone who wants to answer this, what are the health consequences of people not being able to take the medication that they need? And who wants to, and if there's anybody really looking at that? Doctor?
I mean, I can begin with this question.
Sure.
I see people every month, if not every week.
Push the button again. Are you green?
I am green.
Okay, then pull it closer.
I see patients every month in my clinic, if not every week, who have suffered direct health consequences of not being able to afford the medicines that they need. And what are the manifestations of this? You can see in so many of the patients that I see in the East Baltimore Medical Center with diabetes, I see them coming in the door with glucose levels, blood sugar levels that actually are so high that the machines we have can't even record them. And there are many reasons why people have a hard time taking their medicines, but when you look at the price of insulin these days, that goes a long way of explaining why my patients can't get the medicines that they need. So immediately you see that in their health indicators, they get on the verge of hospitalization. More broadly, you see ways it affects the health system and health expenditures in general.
Oh, go ahead. Sure, go ahead. I appreciate it.
With the Ohio Public Employee Retirement System, we've done the best that we can to actually keep our patient cost share low. For generic drugs, actually patients pay $4 for a 1 month supply. Our specialty biologic drugs that I mentioned, our members will pay at most $60. We know that it's extremely important to keep the cost share low to remove that financial barrier to taking the medication and preventing any kind of medical complications such as going to the hospital. So we definitely believe that the copays need to be low to prevent things such as pill splitting and missing doses, which will lead to negative medical consequences.
Go ahead.
Similarly, as you all know, Medicaid is statutorily prohibited from imposing significant cost sharing, or put another way, states have the option to implement minimal cost sharing for beneficiaries. And I think that because of that, there is certainly a desire by states to ensure that enrollees are taking their medications appropriately. And many care management programs have been designed specifically with prescription drugs in mind to ensure that patients are taking them, and to monitor the full continuum or the range of medications that individuals may be taking as well. It's an important piece for Medicaid.
Thank you. Did you want to say anything, Lynn? So a report was just released today, Wyden, Grassley, Savaldi investigation, looking at those. And we're talking now about billions of dollars being spent by the taxpayers on these drugs. One of the things that Congressman Welch and I have had is to have for Medicare, to allow Medicare to negotiate for lower prices. And then I have a bill also that would allow what the bill would do would allow not only negotiation, but would introduce legislation to require greater transparency for drug pricing, including requiring that price increases for drugs already on the market be publicly justified. That, it's one thing when the pharmaceutical companies talk about the R&D, but what is the reason? Why are they? Is this just because they want to make more money? And what is your solution to that?
I think that this question that you're asking about transparency and the idea of cost justification is essential. I think that we will see that it is hard to justify the widespread markups that we're seeing. And I think the stories told by this panel about what the drugs used to cost amply demonstrate that. I would still do it, but I think that we will have to probably take other measures because right now it's legal to do this.
Exactly. This is a legal ripoff by the drug companies of taxpayers and consumers.
Mm-hmm.
Right now, we're going to have to go to, we have a number of members here, and we want to try to get to them. Thank you. I want to recognize Mr. Cummings. I know that he has to leave, and then if he has time, then Mr. Becerra.
I'll be very brief. Thank you, Madam Chair. Let's not kid ourselves. We can dance around this all we want. This is about greed. Come on now.
Amen.
We want to be politically correct while people are dying. Mr. Greene, as I see it, this can only get worse because companies are seeing that they can get away with it, and then other companies are saying, why don't we do it too? Would you agree?
I certainly agree. I think that we see an arena in which we used to expect only high prices to be charged for on-patent drugs, and now we're seeing a broader exploration of ways in which monopoly power can be used in older off-patent drugs. And as long as these cases work, why won't other companies do it as well?
And can you see any other reason for this than greed? Do you? I mean,
I think original sin comes as no surprise. So it's the greed of the industry is very clear. They're going to maximize profit wherever they can. I think the question is, how can we structure it such that that's not permitted?
And Madam Chair, one of the things that we need to keep in mind, a lot of companies will say, and these are good companies doing the right thing. They'll say you're trying to stop companies from making money. There's nobody on these panels that have a problem with pharmaceutical companies making money, reasonably, that is. And so that's not the issue. And I think that the companies that are doing the right thing ought to be joining with us. So to get rid of the bad apples, to bring some credibility here, would you agree? Now, come on, I can't hear you.
I should
I see you shaking your head. I like that.
Well, I would absolutely agree. And I think it's not only members of this panel, but it's the American public. We've done a lot of qualitative research with consumers. Where are they coming from with respect to high costs? And they're particularly worried about high drug costs, and they do not want to see excess profit taking, because this is a life-saving medication that they need. They view it as what we call a social good. This isn't something you can charge as much as the market will bear. It has to be priced so people can get it.
The other thing that we've been concerned about, all of us, have been this whole income disparity situation where income inequality. And if you think about it, you can be in the middle class. And if somebody takes your pill from $13.50 to $750 the same day, you can be in the lower class within literally seconds. Am I right? So this also goes to trying to help Americans live decent lives and allow them to stay in the middle class. With that, I'll yield back. Thank you.
Thank you very much, Mr. Cummings. I think what we will do, because we do have a number of members and time wasting, is take a question from Mr. Becerra and a question from Ms. Davis, and then we'll have the panel respond. And we have the outstanding questions from Mr. McDermott.
Thank you, Madam Chair. If I can just ask any of the witnesses, and thank you again for being here and for raising all these critical points. Correct me if I'm wrong. My understanding is that this is an issue that impacts a whole lot of Americans. My understanding is that around half of all Americans are using some form of prescription medication, but that for seniors, am I correct? I heard it was something around 90% of seniors are taking some form of prescription medication, that there are close to 500,000 Americans who are paying more than $50,000 each person for some of their medications because they've got these illnesses that require a lot of this medication that's very high cost. And my understanding is, this one caught me by surprise, that Americans pay more out of pocket for their prescription drugs than they pay for their hospital bills. Are those numbers correct? That's the question I'd like to ask. Are those figures accurate? We need to get a sense of really how Americans are being impacted, because this isn't just grandma needing some medication or the unfortunate individual who is on a fixed income who now needs to have this very expensive medication. This is a whole lot of Americans who are going to be impacted if we continue to see these drug prices just go obscenely out the door. That would be my question.
Ms. Davis?
Thank you all for being here. I think one of the questions that we often grapple with is how you measure the benefits of a drug and why we don't somehow calculate that into the cost itself. Are there any suggestions that you have that would get us to that point? I think we're all dealing with the benefits of innovation, but we want the transparency. In your experience, How do we calculate that so that we know that for diabetes, for example, the cost savings are great? Those who have life-threatening cancer illnesses, obviously, that's enormous. How, do you see incidents where we do that? How would we do that?
Absolutely. Do you want me to start?
Sorry.
All right, I'll be quick, because I think we all have a lot to say about both those questions. First of all, I would confirm the statistics that you mentioned, and I'll briefly, except for, I'm not actually familiar with the one about over $50,000 a year. I will say that the reason insurance coverage for drugs can be at a much lower coinsurance rate than other things, which is why you get this phenomenon of paying more for drugs than for your hospital stay. This is Representative Davis, you asked a wonderful question. Consumer Reports actually has a program called Best Buy Drugs, which looks at the safety and efficacy of categories of drugs, not every single drug, and then looks at the average wholesale price and tries to come up with what is a good value for consumers. So this absolutely can be done. It should be done. There's lots of other approaches, research approaches to doing the assessment that you're trying to make. But we also have some holes. We have areas where the comparative effectiveness research has not yet been done. And the only thing about we know about that drug is that it's better than a placebo, which is a sugar pill. So there's a lot we can do in that space. I'm going to let somebody else answer.
I'd just like to add to that certainly safety and efficacy are important, but it's also important to keep in mind the particular population that is receiving the product. So there are unique issues to individuals enrolled in the Medicaid program, and it may be more than just safety and efficacy that determine whether a drug regimen is appropriate for an individual at any point in time. I would also point out that unlike the commercial marketplace and other programs, Medicaid is constrained by certain statutory requirements that don't allow states to determine or to exclude one product over another. And that has been a barrier for the program to date.
And I would add to it what both my co-witnesses have said, that the problem of value and of comparison in the pharmaceutical area is one that's repeatedly been obstructed by proceedings that make it very difficult for our federal government, certainly, to actually not only negotiate prices, but even combine information of cost with effectiveness in the way that we compare pharmaceuticals. And if we look at some successful public and private ways of doing so, I would look back at the Drug Effectiveness Review Program that was put together by member states, trying to find ways of working around barriers to actually create their own ways of comparing drugs within categories and facing a series of legal challenges in the process. Meanwhile, what we've seen evolve instead is this industry of PBMs, of pharmacy benefit managers, which do that work on a private basis of trying to evaluate drugs within class, but without needing to divulge the actual relationships they have financially through discounting and bundling. So we've tacitly endorsed a private and obscure system of comparing drugs rather than favoring a public and open one of doing so.
And with regards to seniors, with our population, our members actually on average are taking 4 maintenance medications, so medications for blood pressure and diabetes. So, these people are, sick individuals taking a large number of medications. Some of these medications, especially the specialty biologic drugs that I mentioned, on average can cost $4,000 a month. We've protected them, as I said, with our plan design, so they don't have to pay that. But if our plan design wasn't generous, they actually would be exposed to paying a large portion of cost share for that. And with regards to paying for drugs on value, that's something that I very much support. That's something that I mentioned. Moving to value based contracting, outcomes-based contracting, actually where we're paying these drug manufacturers on the effectiveness of the drugs, I think is critical. Moving away from this current system of just paying for the drug as they come out with the pricing, that needs to change. Other countries are doing that in the world. Indications-based purchasing, contracting, that's something that's also could be effective, where you're actually paying a higher price for an indication where it actually works, like maybe adds 4 months of life, and pay less for an indication where it doesn't work, where maybe it adds just 1 week of life. So those are the type of things that need to occur. And talking about cost effectiveness analysis, comparative effectiveness research. These are things that are fragmented and being done in places. The government has been restricted from doing cost effectiveness analysis, but CORI can't do it, AHRQ can't do it. Some private sector entities like ICER are actually doing it to try to then incorporate that into decision-making and negotiation on drug prices for PBMs.
Mr. McDermott, if you could repeat your question, and then Mr. Welch ask your question, and then we'll have the panel respond.
Well, my basic question was, we've gone around it. The problem for the Congress is, how do we control the costs? And we have taken away the power to negotiate for the secretary, which is a kind of a free market aberration, if you will. One could do like we do with electricity, that is treated as a essential of the society, and put it under some kind of regulation scheme where you had a drug pricing commission that would make the decision. The toughest thing for us is to figure out, what is the real price? What is the real cost to a drug? Why should it be different in Seattle than it is in Miami or in Houston, Texas, or in Vermont? It ought to be the same price everywhere in the United States. But what we're stuck with is the advertising costs and the whatever other costs that go into it. I don't know. I worked at GD Searle when they developed Inavid back in the 60s, the first drug for preventing pregnancy. And we worked to get every drop of everything out of every barrel of liquids and everything else. And I understand there's some real difficulties, but what's the best mechanism for us to figure out how to protect the American people from what people have called greed?
Representative Welch.
I want to thank my colleague. The pharmaceutical companies are saving lives and relieving pain, but they're also killing us with the cost. That's number one. Number two, the patients are really, it's out of reach for patients, it's out of reach for the taxpayers, and it's becoming out of reach for a lot of our local hospitals. And the fact is that if medication, you mentioned this, Dr. Greene, in a very painful way for your patient and for you, if they're out of reach, they're useless. Bottom line, the market is broken. There is no market, no competition. And what has happened is that the financial manipulators are able to leverage their ownership into punishing prices. So my colleague, Mr. McDermott, asked the question that really, Jim, we have to answer. What can we do? But I think it starts with the proposition that if a drug is unaffordable, it's useless, and the drug market pricing system now is completely and utterly broken. But I thank you all very much for your work in putting it in such coherent form that we may be able to get something done. Thank you. And thank you.
Response to Mr. McDermott.
I can take a quick response, which is to say that this is, I think the two of you are both illustrating precisely why I think this should be a bipartisan issue, is that we're not talking about classic elements of responses that need to be solely Democratic and not Republican. We're talking about making markets work, and we're talking about competition and free market policy. And in the arena in which monopoly power allows access and affordability to go away, there's a number of things I think we could do. I've mentioned before that I think subpoena power and actually illuminating the true pricing process would do a tremendous amount. I think that there's a lot that could be done to monitor when a competitive drug market is becoming less competitive. We don't do that, but we could. It wouldn't be that hard. The FDA could initiate a fast track for bringing a drug back in. For once a market is dwindling to an oligopoly, it's not hard to imagine a fast track or a green light for approval of generic drugs in that field.
Could we use the GAO?
The GAO would certainly be a way of getting into this. We also have means that we don't use, such as parallel importation. and compulsory licensing. And one of the reasons we don't do that is we seem to be skeptical of drugs approved in other nations. But certainly the European Medicines Agency, if you look at the case of pyrimethamine, Glaxo, the original manufacturer, sells it for 66 cents a pill in the UK. Are we not going to trust the version of the pill made by the original manufacturer in the UK? It would seem that if you had a parallel import mechanism that you could use by a certain subset, like maybe you don't want to trust the 2 cent a pill version in Brazil, although I think it could quite possibly be trustworthy. But you could easily imagine a way in which, for a subset of other countries, we could institute parallel import things ready to go if and when a drug turns into an oligopoly or a monopoly again. But those are a few ideas. They are certainly things that I would love to see Congress take up, but mostly I would encourage you to continue to shine a light on this area.
I'll just, if we have a few seconds, I'll respond specifically to the idea of we regulate utilities. I think the task force should use its investigative powers to look at a staged approach, one that starts with transparency, that asks these questions about, show us your marketing expense, show us how you're accounting for R&D, and how much of that R&D was originally paid for the taxpayer. What if you think you can justify $100 a pill in this country, why is Britain paying $17 a pill? So part of
True that generics can be a major factor in reducing drug prices, or has somehow the marketplace changed? And if it has, what can we do to get them back so that they play the major role that, myself and others have always expected them to play?
I'm happy to start in that. I'll be brief so that my co-panelists can speak as well. I prescribe generic drugs. I use generic drugs. When my kids get strep throat, they take generic versions of amoxicillin. I think that the generic drug industry has done a great deal to create a competitive environment in which real cost savings have really helped American consumers achieve high-value health care, and I believe very strongly in that. And I think it continues to do so. I think the problem that we're learning is that as generics become more and more of the marketplace, right? Less than 10% in 1960, more than 84% last year. We are seeing a consolidation of the industry. We're seeing a transforming set of industry dynamics. The companies which we thought of as these little pharmas, these small mom and pop competitive, have become as big, if not bigger, than what we used to call big pharma. They're multinational corporations in their own right. And what is also happening is that we have these assumptions about generic competition that happen in some parts of the marketplace. Amoxicillin, you've got 10 different companies with Orange Book approvals right now. But if you look at these other arenas, like I would say spaces like insulin, where you don't see generic competition emerging, even though it's a drug with vast public health significance, we realize that our reliance on generic competition has been insufficient. And I think the area just requires a lot more scrutiny to understand how and why players like Turing and Amedra can come in and do what they've been doing.
Thank you.
Dr. Greene made some excellent points about the shift in the marketplace. I guess with respect to the Medicaid program, there are some unique things to keep in mind, and that is that the drug rebate program, that the provisions around that impact whether generic products are, in all cases, the most, the cheapest product available. So I would just urge members of Congress to keep that in mind as well, that the negotiations around drug rebates may, in some cases, make a brand product the better choice from a financial standpoint.
If I can quickly add, and I think industry watchers predict that switching to generics is going to represent less cost saving in the future than it did in the past for a number of reasons. There's fewer competitors. There are the problems of material shortages that we've referenced. And also biosimilars, which is kind of a generic version of a biologic drug, are not expected to generate the cost savings we saw for the non-biologic. So for many different reasons, they helped us in the past, and but generics will help us less in the future.
And there's nothing we can do to make them more effective or competitive and, go back to the good old days, so to speak?
Yeah, I think, again, the generics for OPERS, we have a 90% generic fill rate and 26% of our costs. So we have relied on generic drug savings to help provide affordable premiums and affordable copays. And what we've seen is actually we can still realize some more savings by using formularies, utilizing prior authorizations to encourage people to use generics, but the savings aren't going to be there like they've been But biosimilars, that's something that I think is a great opportunity, especially interchangeable biosimilars. We definitely need a marketplace that's going to encourage biosimilar competition. Between $44 and $250 billion in healthcare system savings could be achieved through biosimilars, interchangeable biosimilars, and we need your help to make that come to fruition.
And I would totally agree. I didn't mean to say that there would be no savings, just that it's not as much as in the past. And I think there are things you can do. And I think it depends on the market as to what needs to be done. How many patients take that generic? Some of these, where it's a very small patient population, the market isn't going to step in and solve the problem. But if there's a large patient population, there's probably things we can do.
Thank you.
Mr. Doggett?
Thank you very much. I'd just like to close since you've described how pervasive this problem is and what some of the practical effects are on individuals in talking about some of the solutions. Ms. Maresca, I know that despite many of the problems you've outlined, that drugs that are obtained through the Medicaid program cost less because there is a rebate system and there is some negotiation that goes on, just as for our veterans who get drugs for a fraction of what some other people pay because the Veterans Administration can negotiate, and the Department of Defense, which is there on behalf of our active duty military personnel and some retirees, all getting less expensive drugs. Many problems despite that, but I think a first step is the kind of legislation that this House passed in 2007 with the vote of, I believe, every Democrat and 23 or 24 Republicans to allow Medicare authority to lower the price for seniors and individuals with disabilities. And then so much of the focus within existing law, you mentioned value-based, the ability of the Center for Medicaid Services as they're looking at implementation of the Affordable Care Act and how they price, how they do demonstration projects, comparative effectiveness, and why that can't be used to get some of this information out, that there's authority there for some action. National Institutes of Health, taxpayers are paying for much of this research that goes into these outrageously price-gouging drugs. We paid to get the research that led to the drug in the first place, but there doesn't seem to be any continuing direct benefit for the taxpayer. And Dr. Greene, particularly on the question of not only more competition, but more openness to get to that competition, what role does transparency and openness, whether we get it at the demand of under some of the existing laws or in opening that process up through new legislation, what difference does that make, in your opinion?
I thank you for that question. I think transparency is key to this problem, and I think again, as I suggested briefly in my testimony, we are hamstrung in our ability to even study pharmaceutical prices by the fact that those real pharmaceutical prices are unavailable. And I think that Sunshine does quite a bit. And again, emphasizing the bipartisan nature of this problem, if we look across at the Senate and the work of the Senate Finance Committee in putting forward the Sunshine Act, looking at physician payments from pharmaceutical companies, that has done quite a bit to change the incentive structures for my colleagues in academic medicine and private practice that think about how and when they accept gifts from the industry. This is a very different problem, but I would suggest that the medicinal value of transparency is just as applicable, if not more, in this case.
Thank you. Thank all of you.
Thank you, and I want to thank our witnesses today. I know I've learned a lot here, and I remembered as I was sitting here many years ago in the 1990s, I was involved in a fight to get a generic production of an anti-arthritic medication, and it was really fighting the manufacturer who had maintained a patent and wanted a patent extension, even after they had already recouped all of their money and then some on their R&D costs. And so I'm wondering what the function is of the Congress in awarding these extensions, and what are some of the factors that we need to look at to make a determination as to whether there's a need to continue to recoup cost. And then if any of you have any expertise and can tell me the role that you think the allocation of the research and development tax credit should play in encouraging innovation in pharmaceuticals as opposed to just the glomming around one drug and failing to continue to develop new drugs and treatments to bring onto the market.
Well, I'll take on one and turn it over to my quite impressive co-panelists here. I absolutely would look at, so there are two reasons why drug companies can have exclusivity on the marketplace. One, because they're still under patent, or one, because the FDA granted them a period of exclusivity, and those can run concurrent or not. And I would bring the FDA in here and ask what rules they look at for granting those periods of exclusivity. I think that we can definitely point to drugs and something that can be addressed to allow drugs to convert to generic form more quickly. And I will not take up all the time. So who else would like to speak?
Well, I'll just comment as well to that, that if what we're really talking about are the effects of monopoly power,
Speak in the
sorry,
microphone.
if what we're really talking about are the effects of monopoly power, even beyond this, there are these soft monopolies that we've been learning develop when drugs are off patent, and I think that just even beginning to realize that we need to be actively surveilling for when competitive markets become uncompetitive and become loci of new, what I would call retro monopolies. We tend to think that there's this life cycle where it starts off on patent and there's high prices or recoup the R&D cost, and then it goes off patent and competition rushes in. But there is this third phase that we need to attend to.
Mm-hmm.
As to your second question on promoting innovation, I think it's worthwhile looking abroad as well for models. I think if we look at the models of value-based payment that have been initiated by NICE in the UK, if we look at other proposals for variable patent length, depending on the degree of innovation that is provided. So again, getting concrete steps into thinking about values that drugs provide, being able to break down the firewalls that we currently have between the parts of the federal government that actually look at things like effectiveness and safety and look at questions of value would go a long way in taking better advantage of those tax credits that you're describing.
Thank you all very, very much. This has been a we read so much in the newspapers. We hear from constituents, and listening to you and enlightening us on some of the facts involved in this effort. Let me just a couple of things. I would like to ask because I sit on the Appropriations Committee that has jurisdiction over the FDA. And what I want to say to you, and I'd love to have the opportunity for you to get back to me on this, which is what should we do with regard to FDA? You've mentioned the one piece of this investigation with regard to drugs, but the approval process, especially taking into account comparative effectiveness. We've had I get very concerned with regard to looking at an expedited a process here because of the safeguards. Forget what's happened with the risks and that information back. It takes years to get that, if you get it at all. Dr. Greene, just so that you know this and we can get you the information, there are a number of pieces of legislation that people who have been here today have introduced. Congressman Welsh on price negotiation. We've had Ms. Schakowsky, Medicare prescription drug savings, Elijah Cummings, a Prescription Drug Affordability Act, No Drug Ads Act, Jerry Nadler, myself with direct-to-consumer marketing ban, and the only one that is bipartisan at the moment is Congresswoman Kaptur's amendment. It was an amendment which passed in the committee on a bipartisan basis. And to my knowledge, and I will look into this to get this information back to you, if there have been any legislation introduced by my colleagues on the other side of the aisle. But you should know that people have been investigating this effort for a while. A couple of things that, in terms of the suggestions that you have made, I want to ask about the biosimilars. And on that, how do they become more accessible to consumers? Should insurers simply cover more of the costs, or should we regulate the prices for these drugs before they enter the market? I will just follow up with that no one here has mentioned what the Medicare Part D bill did not allow us to do years ago, and that was for the federal government to negotiate price. And what your view is on that. Many years ago, we had an opportunity for legislation on the reimportation of drugs from FDA-approved facilities. We are now also prohibited from doing that. So regulate the biosimilars before they get to market. Insurance companies cover more of the costs. Negotiating price. And your view on reimportation.
For Greene? I think she said Dr. Greene.
So I thank you for these questions. I'll take them in order. In terms of regulating, so when you say regulating biosimilars, are you referring to all biologicals or the follow-on biologicals? You mean the off-patent versions?
Right. It's the follow-on.
Exactly. So the off-patent. The key problem I see with the way that we are regulating biosimilar drugs is that we've created two different pathways, which separates the incentive structure by which generic competition produces cheap drugs, right? On the one hand, you've got this biosimilar pathway in which all you have to do is prove it's basically the same thing, but then you can't market it as exchangeable, so you have to spend a lot of money on marketing the drug. The other is an exchangeable pathway in which you don't have to spend money on marketing the drug, but you need to do additional studies, more expensive clinical trials to demonstrate that it's actually exchangeable. And so as a result, we've separated these two planks of what made Hatch-Waxman help create a competitive generic drug industry. So if there's a way of putting them back together again, and I think there would be, that could actually create a more competitive biosimilars market. The second question of insurance coverage, I think this is a tremendous problem we're seeing as what is called consumerism, or in the healthcare market means that consumers have more skin in the game or are paying more costs, and we see it every year. I don't know how to make insurers roll that back. Certainly if you could, I feel that I'm getting much less value out of my health insurance these days as a consumer, but that's because of my exposure, of how much more I have to pay. The third question that you have about Medicare Part D, I think, again, here is something where almost immediately we should be able to do this, right? As a historian, as a policy scholar, I'm still amazed that when you compare us with other industrialized democracies, that we don't allow negotiation of prices. It would seem to be an easy fix, except for the fact that it's not. And then the question of the FDA that I think you brought up, it fascinates me. And I think the FDA has traditionally not been allowed to consider economics. But when we think about things like a priority review pathway, and I agree, I think it's very important to step back anytime the idea of an expedited review comes up to make sure that we don't cut any corners. And certainly that there are many corners that it has been proposed that we cut in recent months on these FDA review processes. That being said, there are established expedited review pathways for things like, for example, new antibiotics, which address public health problems. And I think if you look at the FDA's already existing priority review pathways, I would suggest that we can add something like a threat of monopoly, a threat of an oligopoly or of non-competition as a trigger flag for a similar expedited pathway, which wouldn't need to cut any corners. It would just bring something to the top of the pile, and that's what I would certainly encourage you to pursue.
May I make a quick comment?
Please.
I just wanted to come back to the insurance issue. Lowering cost sharing for consumers would be welcome, except it should be considered a short-term or a stopgap solution, because when you lower cost sharing for consumers, that means the health plan's paying more, and you see it in your premiums, which are also extremely difficult for consumers to afford. So I think it can be a good policy, but it shouldn't be the only thing that we're doing. And one of the attractive things about some of these cost-sharing measures is it can help address these discriminatory benefit designs where, every single drug, even the generics, for for a disease like HIV is put in the highest cost-sharing tier, but it should absolutely not be the only thing that we're looking at, because we just pay it when we pay the premium.
And with any expedited pathways and follow-on studies, we've always suggested that those studies keep in mind particular populations, individuals with mental illness and addiction disorders. Types of populations that Medicaid traditionally serves are usually not accounted for in follow-up studies, and it becomes a concern for us when products are brought quickly to market, that individuals expected to be immediately available when they're not, and states are not able to put in place policies that would reflect certain conditions. With Part D, I think it's worth mentioning that the rise in Part D costs is not lost upon states, even though states are not directly paying for pharmaceutical prescription drugs for Medicare, Medicaid dual eligible. States are still paying for, still on the hook for that quote-unquote clawback payment that was included as part of the law way back when. So the rise is not only hitting states on the state within the Medicaid program, but also that payment on the Part D front as well.
I think with regards to the FDA, making sure that the biosimilar pathway, the 351K pathway, is actually something that promotes the approval of biosimilars, especially interchangeable biosimilars. These interchangeable biosimilars that, just like under Hatch-Waxman, you can substitute a generic for a brand. You could substitute an interchangeable biosimilar with a biologic. The approval of interchangeable biosimilars is going to be critical to consumers and to plan sponsors across the country, so individuals can get these lower cost interchangeable biosimilar products. The FDA, again, doesn't look at the financial aspects of things. They're looking at safety and efficacy. It's going to take public sector and private sector entities kind of supporting the FDA to evaluate the comparative effectiveness of drugs, the cost effectiveness of drugs, the value of drugs. That's going to need, I think, to happen in support of the FDA. But if there are some areas of overlap, those kind of discussions should occur, such as, should the FDA require, when approving a drug, comparing it to a standard of care drug that's already on the marketplace.
Right, exactly. Okay. Let me just say thank you to all. I'm going to make the comment, and because I'll close, and then Congresswoman Edwards will as well. But I'm assuming that you think it's a good idea for us at the federal level to be able to negotiate price. Everybody agrees with that. Okay, so that's something that we can take a look at. We thank you for your suggestions, but thank you for your thoughtfulness on this and your willingness to speak with great candor and provide us with your suggestions. We're very serious about this. My colleague, Congressman Doggett, initiated this task force, and a number of members are participating in, because this is a serious issue that we believe that we need to tackle. And the American people, I believe at this moment, feel that they're pretty much on their own on this, and they're struggling to try to figure out how to survive, literally how to survive. And we have a responsibility here, because there is the opportunity here to help to address that issue and to help them to survive. So thank you all very, very, very much for being here today. Congressman Edwards.
Thank you very much. And as you can see today, thanks so much to the witnesses, because you could see today by the participation of so many of our members that there's probably not a single one of us that goes back to our congressional district and doesn't at one point or other hear the challenges that consumers are facing. And so you've outlined a series of things that we should consider that are both legislative, but also some things that we should consider as recommendations to the executive branch that it can do now without necessarily having express congressional authority that is within their purview. Because the fact is that, when you outline the health concerns and the risks, and you have people who are cutting back on medication, taking expired medication, not taking medication at all that they need to save their lives. This really is a life and death issue and health issue. And so thank you so much for joining us today, and we will follow up. Thank you.
Thank you.
Emma, this is the leader's room. This is the leader's left. Let's say hello to the